Hello and good evening all. We are going to commence the lecture now on benign anorectal condition. So if you have your question, you note them down. After the lectures, we will now entertain questions. Okay. Now, our outline for the lecture follows. We'll talk about an introduction of anorectal conditions, the surgical importance of anorectal conditions, relevant anatomy. Then we will now talk of the common anorectal conditions. There are several anorectal conditions, but we will only discuss on the common ones. Okay, by way of introduction, benign anorectal diseases are commonly encountered in clinical practice and have significant impact in patients' life. They may present to the clinician as an emergency that requires urgent intervention. They may affect the quality of life of an individual. Any patient with anal or perianal symptoms requires a careful history and physical, including a digital rectal examination, except in condition where it may be contraindicated at that moment. But any patient presenting with an anorectal condition will require a digital rectal examination during your evaluation and further evaluation to arrive at an accurate diagnosis. Okay, differential diagnosis of benign anorectal conditions are malignant conditions. Hence, careful assessment is mandatory. Of course, if a patient has a malignant condition and it was assumed to be a benign condition, so there is tendency of patient becoming complicated. Okay, patient will now be presenting with something that has gone beyond a local treatment. So all patients presenting with benign anorectal conditions should be thoroughly evaluated, not to miss out a malignant one. Now, the management of benign anorectal disorders is challenging for the treating surgeon, as the patients are highly distressed. The symptoms are always alarming, and surgical intervention may be associated with a lifelong disability, such as loss of sphincter control. Now, it should be clear that when you are managing an anorectal condition, there may be collateral damage, which the feared one is loss of sphincteric control. Hence, you have to be extremely careful during your evaluation and also the management. And a surgeon should also know what stage or what condition may not require surgical intervention because of the attending complications they may develop. Now, understanding anorectal conditions require proper understanding of the anal and rectal anatomy. It should be noted that the anal canal is the final segment of the gastrointestinal tract with length of 4 centimeters. What is the extent? It is the continuation of the rectum and ends at the anus. The anal canal is surrounded by internal and external sphincters, which play a crucial role in maintenance of fecal continence. The internal anal sphincter surrounds the upper 2/3 of the anal canal. It is formed from a thickening of the involuntary circular muscle of the bowel wall. As we know, the large intestine has an inner circular muscle and the outer longitudinal muscle. So the internal sphincter is derived and the continuation of the circular muscle of the large bowel. And you can see it's depicted by this blue painting on the diagram. It covers 2/3 of the upper 2/3 of the anal canal. The external anal sphincter is the voluntary muscle, okay? You can see the internal is involuntary. The external is the voluntary muscle that surrounds the lower 2/3 of the anal canal and so overlaps the internal sphincter. It blends superiorly with the puborectalis muscle of the pelvic floor. So the internal sphincter is the inner circular muscle, which is involuntary, and the external anal sphincter is the outer muscle, which is voluntary. The mucosa is organized into longitudinal folds known as anal columns. You can see this yellowish part, okay, is depicting the anal columns. These are joined at their inferior ends by anal valves. Above the anal valves are small pouches, which are referred to as anal sinuses. These contain glands that secrete mucus. Okay. Now, if you have within the mucosa a column, okay. Now, this column form the anal valve at the lower end here, okay, and the anal glands open obliquely like this, okay. Their secretion goes into the columns through the valves. These valves are also called crits. The secretions are very important for the purpose of adequate lubrication and passage of the content. Anal valves collectively form an irregular cycle known as the pectinate line or the dentate line. At the level of the anal valve or the anal crits forms the dentate line. Now, this line divides the anal canal into two halves, the upper half and the lower half. Upper 2 centimeters and the lower 2 centimeters, which differ in both structure and neurovascular supply. This is a result of their different embryological origin. Above the dentate line is derived from the hindgut. So it has a visceral supply. Below the dentate line is derived from the proctoderm. That is the ectoderm, which has somatic innervation. And this anatomy is very significant because the somatic innervation, lesions in part of this canal that are located below the dentate line are painful because of the somatic innervation. Lesions above the dentate line are painless because of the visceral innervation. The arterial supply of the anal canal. Now, the upper part is supplied by the superior rectal artery. The lower part is supplied by the inferior rectal artery. Branch of the internal pudendal, both anastomose with the middle rectal artery, which is a branch of the internal iliac artery. So the anal canal, the part above the dentate line, is supplied by the superior rectal artery. The part below the dentate line is supplied by the inferior rectal artery. Both of these arteries anastomose with the middle rectal artery, a branch of the internal iliac artery. Venous drainage. Superior rectal vein, which empties into the inferior mesenteric vein, that is the portal venous system, drains the upper part of the rectum, of the anal canal. Inferior rectal vein, which empties into the internal pudendal vein. These drains the part below the dentate line. The innervation, as we mentioned, okay, visceral innervation via inferior hypogastric plexus. It is sensitive to stretch, no pain fibers. Now, this supplies the part above the dentate line. Somatic innervation via the inferior rectal nerves, branch of the pudendal nerve, sensitive to pain, temperature, touch, and pressure. Now, the lymphatic drainage of the anal canal. The part above the dentate line is drained by the internal iliac lymph nodes, while the part below the dentate line is drained by the superficial inguinal lymph node. That's why you see lesions in the anal canal, for example, anal carcinoma, okay? Anal margin tumors. They spread to the groin because the lymphatic drainage is via the superficial inguinal lymph nodes. So this is very important in understanding the pathology of the benign anorectal conditions as well as the malignant one. Okay, the concept of the anal cushions is also very important for you to understand. Anal cushions. The anal cushions are composed of blood vessels, smooth muscles, the tricep muscles, and elastic connective tissue in the submucosa of the anal canal. They are located in the upper anal canal from the dentate line to the anorectal ring. Now, these anal cushions are a collection of both vessels, muscles, connective tissue in the upper part of the anal canal, and they are important also in contribution to continence of an individual. Now, the reason why you need to understand this anatomy is in relation to hemorrhoids, because it is when you have protrusions of these anal cushions that hemorrhoids develop. Hemorrhoids are nothing but protrusion of anal cushions. Okay, let's start with hemorrhoids. Hemorrhoids are defined as an abnormal swelling or enlargement of the anal vascular cushions. The anal vascular cushions act to assist the anal sphincter in maintaining continence. There are 3 vascular cushions in the anus, positioned at 3, 7, and 11 o'clock position. When you look at the patient in lithotomy position, okay? Patient in lithotomy position, this is 12 o'clock. This is 6 o'clock. This is 3 o'clock. Now, these vessels or hemorrhoidal cushions are located in position 3, position 7, and position 11. Now, all primary hemorrhoids take these positions. These also form a basis for classifying hemorrhoids into primary and secondary, because those that will protrude at the primary hemorrhoidal Cushing's are called primary hemorrhoids. Those that come in between are secondary. But generally, what you should know is hemorrhoids, okay, commonly protrude via the positions of the vascular Cushing's at 3, 7, and 11 o'clock. When these Cushing's become abnormally enlarged, they can cause symptoms and become pathological, termed hemorrhoids. By the way, you should know that hemorrhoids are not varicose veins. They are abnormal protrusion of hemorrhoidal Cushing's or anal Cushing's. Okay. The prevalence of hemorrhoid varies, estimated at 4.4% worldwide. Commoner in the Western world, okay? Commoner in the Western world. 2.2 to 7% in England and 0.7% in Africa. The higher prevalence in Caucasians is due to increased consumption of refined carbohydrate products, unlike in Africa. Of course, because of westernization and adoption of Western diets, hemorrhoids is in the rise in Africa. Age distribution, a peak between age 45 and 65 years, and a subsequent decline after age 65 years. Now, what are the types of hemorrhoid? Hemorrhoids could either be primary and secondary. As we mentioned, primary hemorrhoids occur at position 3, 7, and 11. These are sites of hemorrhoidal Cushing's. Secondary hemorrhoids are those that develop anywhere in between the positions of the primary hemorrhoids. Hemorrhoids could either be external, internal, or mixed. Hemorrhoids that develop below the dentate line are called external hemorrhoids. Hemorrhoids that develop above the dentate line are called internal hemorrhoid. When there is hemorrhoid that involves both above and below the dentate line, it is a mixed hemorrhoid. External hemorrhoids are covered by skin. Internal hemorrhoids are covered by mucosa. Now, grading of internal hemorrhoids is another way of looking at their classification. They can be graded, which we will see shortly, and this grading is with respect to internal hemorrhoids. Hemorrhoids can also present as thrombosed hemorrhoid when the veins draining the hemorrhoid are blocked with clots, and hence you see them engorged, and usually they are very painful. Or they could be strangulated when a thrombosed hemorrhoid persists for a very long time. Even the arterial supply is impaired and it undergoes necrosis and ulceration. So when you see a thrombosed hemorrhoid that is ulcerated, it becomes, okay, it becomes a strangulated hemorrhoid, okay? Now, so these are the various types of hemorrhoids. Now, the grading of internal hemorrhoids, they are graded from first, second, third, and fourth degree. The first degree hemorrhoids, they remain in the rectum. They do not protrude. Their symptom is bleeding. Second degree hemorrhoids, they prolapse through the anus on defecation but spontaneously reduce. Third degree hemorrhoid, prolapse through the anus on defecation but requires digital reduction. They require a manual reduction. Fourth degree hemorrhoid remain persistently prolapse. So these are the various types of hemorrhoids. Don't forget primary or secondary, external, internal, or mixed. Then grading, the grades 1 to 4 of internal hemorrhoid, thrombosed or strangulated hemorrhoid. What are the risk factors? If you have questions, okay, you hold on. After the lecture, I'll entertain your questions. The main risk factor for the development of hemorrhoids are excessive straining. That is the main risk factor, excessive straining. This could be from chronic constipation, okay, or any form of straining from maybe bladder outlet obstruction, chronic cough, or any source of increased intra-abdominal pressure. You know, when you say straining, of course, there's exertion on the anterior abdominal wall musculature. So, increasing age and increased intra-abdominal pressure such as pregnancy, chronic cough, or ascites. All these are risks for hemorrhoids. Other less common risk factors include pelvic or abdominal masses, family history, cardiac failure, portal hypertension. Now, please, you should note that any patient above the age of 40 years presenting with hemorrhoid, he should be thoroughly evaluated. He should even have a colonoscopy because rectal masses can present with tumors compressing on the rectal veins, and patients will present with hemorrhoid. I remembered a patient who was referred to me to operate upon. Okay, I was told she had hemorrhoids They prepared her. She already bought all the materials, even the stapler for operation. So when I came to review the patient, I took a detailed history. I wanted to examine. She said there is pain. I said, okay, let's go to the theater. Under anesthesia, I'll do a proper examination. And lo and behold, under anesthesia, there was a tumor in the rectum. I took biopsy and it turned out to be an adenocarcinoma of the rectum. So if you go ahead and just treat a hemorrhoid without proper evaluation, you might be missing something. How do they present? Hemorrhoids typically present with paleless, bright red bleeding, commonly after defecation, and often seen either on paper or covering pan. Importantly, blood is seen on the surface of the stool, not mixed in. When a patient has change in bowel habits and bleeding per rectum, you want to know the relationship of bleeding with stool. If the blood is completely mixed with the stool, you know that the lesion causing the bleeding is above the rectum, is far above the rectum, maybe from the transverse colon, descending colon, or even sigmoid. Melena is upper GI and sometimes ascending colon or cecum. So when it's completely mixed with the stool, you know it's a lesion above the rectum. When the blood is coating the surface of the stool, it is coming from the rectum because the rectum is just about 12 cm. So there is no sufficient time for the blood to completely mix with the stool. So it just coats the surface of the stool. When the bleeding is coming after defecation, the bleeding is from the anal canal. That is what you see in hemorrhoids. There is bright red blood seen on the surface of the stool, which usually come after bleeding, or it will just splash on the commode or the toilet pan. Bright red blood. Oftentimes you see the blood dripping after defecation. Other symptoms include pruritus due to chronic mucus discharge and irritation, rectal fullness or an anal lump, and soiling due to impaired continence or mucus discharge. We told you that the hemorrhoidal cushions form parts of the continence mechanism of the anal canal. And now these cushions are prolapsing. So sometimes they could have soilage of their underpants. Now, large thrombosed hemorrhoid, large prolapsed hemorrhoid can thrombose. They are very painful, and this patient frequently present acutely to emergency department. Examination will usually be normal in hemorrhoid unless the hemorrhoid have prolapsed. Now, for thrombosed hemorrhoid, The prolapsed hemorrhoid will present as a purple or blue edematous, tense, and tender perianal mass. It is very tender. You cannot do a digital rectal examination because of the pain and tenderness. And mark you, in such situation, we don't hurry to operate them, because when you operate, you might disrupt their sphincter mechanism and patient will develop incontinence. So usually we commence intravenous fluid, antibiotics, analgesic, sit bath until the edema subsides, and subsequently we can do hemorrhoidectomy for them. Investigations. Proctoscopy is typically performed to confirm the diagnosis. Any significant or prolonged bleeding or signs of anemia will warrant a full blood count and a clotting screening. You should know that in men, one of the commonest causes of anemia is hemorrhoid in men. When you see a man who presents with anemia, unexplained anemia and weight loss, you should start evaluating for a right-sided tumor. Because right-sided tumors, they commonly present with the 3 A's of malignancy: anorexia, anemia, and asthenia. But when you see a male presenting with an unexplained anemia only, you have to fully evaluate for a bleeding hemorrhoid, because you see grade 1 hemorrhoid, as we mentioned, they do not prolapse, they remain in the rectum, they only bleed. Colonoscopy is often advised, especially if complicated hemorrhoids, to exclude any concurrent anorectal pathology before any surgical intervention for hemorrhoids is started. And this is very important in any patient that is more than 40 years. Because rectal tumors will compress on the hemorrhoidal vessels and you see engorgement. When you concentrate on treating hemorrhoid without full evaluation, you might miss out a rectal tumor. The management. Nearly all hemorrhoids can be managed conservatively, especially if uncomplicated. Nearly all hemorrhoids can be managed conservatively, especially if uncomplicated. Ensure to provide lifestyle advices such as increase daily fiber and fluid intake to avoid constipation. Okay? Prescribing laxative if necessary. Topical analgesics. Topical analgesia such as lidocaine gel may also be required for pain relief. Avoid oral opioids, opioid analgesia, as this can compound any constipation and worsen symptoms. Sit bath with hypertonic saline is also advocated. Symptomatic first and second degree hemorrhoids can be treated with rubber band ligation. This involves the hemorrhoid being drawn into the end of a suction gun and a rubber band placed over the neck of the hemorrhoid. This can be done either in a clinic setting or in the theater. This is usually an office procedure. Now, injection sclerotherapy also, where you inject 5% phenol in almond oil. Okay, the sclerosant is actually the almond oil. This is just an antiseptic. Infrared photocoagulation, electrocoagulation, cryotherapy. All these are relevant in managing first and second degree hemorrhoids. Surgical treatment. The various options include hemorrhoidal artery ligation, also termed transanal hemorrhoid disarterialization. Is one surgical option for second and third degree hemorrhoid. Here it is just the feeding vessels that are ligated and the hemorrhoid spontaneously undergoes infarction. Hemorrhoidectomy for third and third degree hemorrhoids. Okay, the common procedure that is done is hemorrhoidectomy, which involves surgical excision of the hemorrhoid. After excising, it could either be closed or left open. Then staple hemorrhoidopexy is also a common procedure that is done in the treatment of hemorrhoids. The details will not be discussed in this lecture. So you should know all the various options, both for first and second degree hemorrhoid, third, as well as fourth degree hemorrhoid. The contraindication for hemorrhoidopexy if there is any perianal sepsis. This picture or diagram is just showing the various steps of hemorrhoidopexy, where a stapler is used to excise a segment. Okay, let's assume this is the anal canal and you have vessels and you have prolapse. Now, what hemorrhoidopexy does is just to take a segment of this mucosa containing the vessels. Okay, when it takes out this segment, it will stretch the hemorrhoid after removing a segment. Okay, these segments have been removed and the mucosa is stretched, the hemorrhoid is no longer there. You can see on this diagram, this is the side that was resected and anastomosed by the stapler. It's not actually, staple hemorrhoidopexy is not actually excising the hemorrhoids. It's rather taking a segment of the mucosa, devascularizing, as well as stretching the mucosa. So these are the suggested plan of management based on the grade of the hemorrhoids, as we already highlighted the various modalities of treatment. The complications, the main complications following surgical intervention for hemorrhoids include bleeding, recurrence, anal stricture or fecal incontinence. Now, let me draw your attention to this bleeding. Hemorrhoidectomy is one of the procedures that is associated with secondary hemorrhage. After the procedure, the surgical site may become infected and they bleed. However, because this bleeding usually occurs within 7 to 14 days after the procedure, and the sphincter is intact, the blood accumulates in the rectum. Patients do not notice. He just feels dizzy and collapse. You now get a history of hemorrhoidectomy. So this bleeding post-hemorrhoidectomy can be a concealed bleeding, okay? And it accumulates in the rectum. Patient just suddenly fall and collapse. Recurrence might occur after treatment. Anal stricturing or fecal incontinence when there is damage to the anal sphincters. Okay, the next benign anorectal condition we are going to consider now is anorectal abscess. An anorectal abscess refers to a collection of pus in the anal or rectal region. They are commoner in men than in women and have high rate of recurrence. 1/3 of patients with anorectal abscess have an associated perianal fistula at the time of presentation. Okay, so at the time of presentation, 1/3 already have anal fistula. The pathogenesis of abscess and fistula is usually the same. They are spectrum of the same disease, with the abscess representing the acute phase and the fistula the chronic sequelae. You can see this image depicting an anorectal abscess. You can see this swelling, hyperemic, shiny skin. All these signifies inflammation and ongoing inflammation. Okay, what are the etiological factors for anorectal abscess? It could be non-specific from cryptoglandular infection. It could be infection involving the anal glands. It could be from specific disease conditions that precipitates anorectal abscess. These specific disease conditions include Crohn's disease, chronic ulcerative colitis, tuberculosis, actinomycosis, foreign body, carcinoma, and so on. Now, the organisms that are involved in this infection are mixed organisms. They are mixed organisms. E. coli, Proteus vulgaris, Bacteroides, Staph aureus, rarely Strep and Clostridium worldchild, and other anaerobes. Rarely you may isolate only one organism, especially in the specific forms of the infection. Now, what is the pathogenesis or the pathophysiology of anorectal abscess? There are 3 steps, 3 things you need to know: blockage, stasis, and infection. Blockage, stasis, and infection. If you remember, when we talked about the anatomy of the anal canal, we talked about the anal columns. Okay, columns of Mogagni. They end in the anal. These are the anal crypts. You have multiple columns like this. These are the anal crypts or the anal valves. These are when you view the inner mucosa. The anal glands are obliquely connected to the anal valves or the crypts. You see the secretions of mucus from the gland move into the anal canal. So when you have blockage of the ducts of the anal gland, this secretion fails to empty. Then you have accumulation, stasis, and infection. Of course, the body tries to fight back. White blood cells are killed, epithelial cells are shedded, bacteria are also killed, and these collective dead cells form pus, and the pus pulls in fluid into the cavity, and creates increased pressure within the cavity. And this pressure tries to gain the least site of resistance to drain. And it now finds its way dissecting through planes until it gains access to the skin where it ruptures. Now, anorectal abscess are thought to be caused by plugging of the anal ducts, which drain the anal glands in the anal wall, normally helping to aid the passage of fecal matter using mucus secretions. Blockage of the anal duct results in fluid stasis, which leads to infection. Common causative organisms, as we mentioned, E. coli, Bacteroides, and Enterococcus species. Obstruction of these ducts, whether secondary to fecal matter, foreign body, or trauma, results in stasis and infection. The anal glands are located in the intersphincteric space between the internal and the external anal sphincter. Therefore, infection from the glands here spread to adjacent area. So you can see the location of these glands are in between the two sphincters. Anorectal abscess can be categorized by the area in which they occur. The abscess could be perianal, it could be ischiorectal, it could be intersphincteric, and it could be supralevator, depending on the position of the abscess. Now, this is an abscess. These are the various modes they tend to track, looking for site for least resistance. And we said the abscess and the fistula are spectrum of the same disease. The commonest types are the perianal and the ischiorectal abscess. The other types are not common. The intersphincteric abscess, it is limited to the primary site of origin and may be asymptomatic or result in severe throbbing pain that resembles the pain of a fissure. perianal abscess result from vertical downward spread of the intersphincteric infection to the anal canal, to the anal margin, and presents as a tender swelling, which can be misinterpreted as a thrombosed external hemorrhoid. Intermuscular abscess within the rectal wall if the infection spread vertically upward. Supralevator abscess if the infection spread vertically upward. May complain of vague discomfort, external manifestations are absent, and the presence of rectal induration and swelling may be clearly established only with the aid of examination under anesthesia. Now, ischiorectal abscess across the external sphincter into the ischiorectal fossa to form ischiorectal abscess. There's also the submucous type across the internal sphincter into the submucous location and burst into the anal canal. Now, the horseshoe abscess. The infectious process may spread circumferentially from one side to the other of the intersphincteric space. The supralevator space or ischiorectal fossa producing a complex horseshoe abscess. The investigations, of course, when a patient has anorectal abscess, the diagnosis is clinical. However, as the majority will require surgical intervention, all the routine investigation in preparation for surgery are requested for. Patients with anorectal abscess without any known fistula-in-ano or other rectal pathology should have fasting blood sugar, glycated hemoglobin checked, because for any underlying diabetes mellitus, because one important risk factor for patients with anorectal abscess is diabetes mellitus or other form of immunosuppressive diseases. For patients with atypical presentation or in those suspicious for a supralevator abscess, complex perianal fistula or perianal Crohn's disease, then additional imaging is required, preferably the MRI. Treatment. Now, whenever patient presents with abscess, they should be started on parenteral antibiotic therapy. Okay? You give parenteral antibiotic, you give analgesics parenterally, okay? Give IV fluid. Then you have to examine under anesthesia and do incision and drainage of the abscess. The drainage you do now depends on the location and the type of perianal abscess. For a perianal abscess, you do a simple skin incision. Intersphincteric is drained by dividing the internal sphincter at the level of the abscess. Both an intermuscular abscess and supralevator abscess, so long as it is not an ischiorectal extension, need to be drained into the lower rectum and upper anal canal. Now, as we mentioned, ischiorectal abscess is one of the commonest type. And how is it drained? Now you do a cruciate incision, as you see depicted on this diagram. You make a cruciate incision, then you now deroove, okay? All these flaps, the 4 flaps will be derooved. If you just make an incision without deroofing, okay, there will be reaccumulation of the abscess. So you make a cruciate incision, drain and deroove the covering flaps. For horseshoe abscess, the deep post-anal space should be drained through a posterior midline incision, extending from the subcutaneous portion of the external sphincter over the abscess to the tip of the coccyx, separating the superficial external sphincter and thus roofing the post-anal space and the ischioanal extension. Para-anal incision can be made and set on place to drain the anterior extension of the horseshoe abscess. Okay. Now, these are various instruction of drainage, okay, for supralevator abscess. They are positioned where to drain and not to drain. Now, a very common distressing benign anorectal condition is fistula-in-ano. And fistula-in-ano is the chronic form of anorectal abscess. Because the acute form is the abscess that presents with pain, swelling, discharge, and all those features of inflammation. When this ruptures, it drains and eventually forms a fistula. If you remember, we said, okay, this is a column, this is the oblique shaped gland, and there's a blockage here, okay? Then there will be stasis, infection, pus formation. Now, this will look for the least site of resistance, drain to the perianal skin, okay? When it gets to the perianal skin, it ruptures to the perianal skin. And when it ruptures to the perianal skin, the pressure within the cavity empties. Okay, you have something like this. Assuming this D, it has ruptured to the anal skin. Okay, so you have discharge of all this content. Now, this opening will now, the obstruction is relieved, and you already have another opening at the skin. And these two tracts are now connected. You can see it's a spectrum of the same disease. So a fistula is an abnormal communication between any two epithelial surfaces lined by granulation tissue. A fistula-in-ano is an abnormal communication between the anal canal and the perianal skin, the peridial skin. Many of these fistulas are easily recognized and readily treated, but others can be very complex and correspondingly difficult to manage. Male predominate in most series. Male-female ratio vary from 2:1 up to 7:1. Age distribution is spread throughout adult life with a maximal incidence between the 3rd and 5th decade of life. Anal fistula usually present with either recurrent perianal abscesses or intermittent or continuous discharge onto the perineum, including mucus, blood, pus, or feces. On examination, an external opening on the perineum may be seen. This can be fully opened or covered with granulation tissue. A fibrous tract may be felt underneath the skin on digital rectal examination. Now, Mark you, when a patient have anorectal, fistula-in-ano, they'll be telling you that they are having recurrent discharge of pus. Sometimes it heals, after some months, it recurs. So the patient will think that that fistula is healing. It is not actually healing. If this is the internal opening, okay, and you have the tract, let's say this is the external opening, okay, what happens is epithelialization, epithelial cells covers the external opening. There's epithelialization of the external opening, and the mucus keeps on accumulating gradually in the tract. Okay? The mucus accumulates, pus, there's stasis, infection, build-in of intra-anal pressure as well as pressure within this tract. Okay? And this pressure now supersedes the resistance of that epithelium, and it now bursts into the perianal skin. So the patient will tell you they are having recurrent discharge. It heals after 6 months, after 3 months, it recurs. The tract is actually still there. You have to intervene. Now you need to understand the Salmon-Gussol's rule, because when you are examining this patient, you need to know the expected size of the internal opening by mere looking at the external opening. The external opening posterior to the transverse anal line. So this transverse anal line is a line that is drawn across the anal canal, okay, dividing the anal canal into an anterior half and a posterior half, an imaginary line. Either patient in prone position or lithotomy position. From this image, you can see patient is in what? Prone position or knee elbow position. And the line is drawn dividing the anal canal into two halves, an anterior half and a posterior half. Now the rule is saying external opening posterior to the transverse anal line. Okay, this is posterior. If there is an external opening here, posterior to the transverse anal line, this is the transverse anal line. Fistula tract will follow a curved course to the posterior midline. So any opening that is located posterior to the line, the tract will take a curved course and open posteriorly at the midline. As long as they are located behind this transverse line, posterior to this transverse line, they will take a curved course and drain posteriorly at the midline. That is for posterior fistulas. External opening anterior to the transverse anal line, transverse line, okay? Fistula tract will follow a straight radial course to the dentate line. So any opening that is located anterior to this transverse line, they will take a straight and a radial course. Okay? They open directly opposite the external opening and at the dentate line. So this is the Salmon-Gussol's rule. Okay? A long anterior fistula is an exception. So there are exceptions to the rule. Exception. Now you should know that Salmon-Gusso's rules state that all openings that are located posterior to the line take a curved course and drain posteriorly to the midline, while those that are located anterior to the transverse anal line take a straight course and drain directly opposites. Okay? But there are some exceptions to the rules. The exception include a long anterior fistula. You can see this is an anterior fistula, but it's long. It's more than 3 centimeters from the anal vag. They are anterior, but they will take a curved course and drain posteriorly at the midline. So the exception to the rule are 1, long anterior fistula. 2, fistula resulting from chronic granulomatous infection. 3, fistula resulting from malignancies. 4, fistula resulting from irradiation, exposure to radiation, okay, and recurrent fistulas. So we are going to take a break, a 15-minute break, then we'll come back and continue the lecture, okay? Thank you very much for listening. So in 15 minutes later, we'll come back and continue the lecture. So we'll take a break now. Thank you very much. Okay, you are all welcome back. We are going to continue the lecture from where we stopped. We talked about the Salmon-Gusso's rule, the rule as well as the exceptions to the rule. In some cases, circumferential spread may also occur in ischiorectal fossa, with the tract passing from one fossa to the contralateral one through the posterior rectum. A fistula is known as a horseshoe fistula. So in a horseshoe fistula, there is a communication of the tract behind the rectum connecting the two fossas, the ischiorectal fossa. Now, how do we classify anorectal fistulas? Now, this classification, there are 4 main classifications, and it is a relationship to the position of the external sphincter. Okay? Now, the 4 main anatomical types of fistula. The external sphincter mass is regarded as the keystone, and the prefix trans, supra, extra refers to it. The puborectalis muscle have been crosshatched for easy recognition. Type 1, intersphincteric is the most common. You can see from the diagrams, it accounts 45%. Okay, the fistula tract is confined to the intersphincteric plane. So the tract is between the internal and external sphincter, and it is the commonest, accounting for 45%. Transsphincteric. The fistula connects the intersphincteric plane with the ischiorectal fossa by perforating external sphincter. Okay? The transsphincteric, which accounts for 30%. The fistula connects the intersphincteric plane with the ischiorectal fossa by perforating the external sphincter. Okay, now you can see this, the ischiorectal fossa is here, and this is the fistulous tract. It connects this to this by perforating the external sphincter. Okay, the suprasphincteric, which accounts for 20%, okay, is similar to transsphincteric, but the tract loops over the external sphincter and perforates the levator ani. Okay, it's similar to transsphincteric, but the tract loops over the external sphincter and perforates the levator ani. You can see this is the levator ani muscle. Okay, and you can see the tract is looping over the external sphincter. Is perforating the levator ani muscle. Okay, so that is the transsphincteric type. You can see it now drains to the perineal skin. Then the extrasphincteric. The extrasphincteric, which is the least common, 5%, the tract passes from the rectum to the perineal skin, completely external to the sphincter complex. You can see this is the rectum. Okay, it passes completely outside the internal and external sphincter. So that is the extrasphincteric, is the least common. Now, but they are named classification. The Milligan-Morgan classifies it into high fistulas and low fistulas, a relation to the anorectal ring. Okay, high fistulas, there's 3 types: the pelvirectal, which is the supralevator, high intersphincteric, and the high submucous. Then the low type are the low subcutaneous, submucous, and intermuscular. We will see the significance of this classification when talking about the treatment of fistula-in-ano. Then there's the Parks classification. Okay, it is the Parks that actually classify a relation to the sphincter into the 4 types we've seen. That is the Parks classification of anorectal fistulas. The investigations you do for anorectal fistula is fistulography. When you have fistula, you do a fistulography by injecting a contrast, okay, into the tract, taking image, and it will give you all the ramifications of the fistula. Okay, now the limitation of this fistulography, it is not showing the relationship with the sphincter complex. Why, when you do the most definitive, okay, is the MRI imaging. It visualizes the anatomy, okay, of the tract. And any surgical intervention can be planned based on this, and you see the clear relationship of the tract with the anal sphincter complex. And it is very important for evaluating a complex anorectal fistulas. It will show you all the ramifications and clearly show you the relationship of this tract with the anal sphincter complex. Now, what are the principles of treatment of anal fistulas? Now, the objective for fistula surgery is simple. Cure the fistula with the lowest possible recurrence rates and with minimal, if any, alteration in continence, which could be a collateral damage, and do so in the shortest period of time. That is your objective for surgical intervention. The principles of treatment. The primary opening of the tract must be identified. You don't just go and be cutting blindly without even defining the anatomy of the tract. The relationship of the tract with the puborectalis muscle must be established, especially in high fistula. Okay, you must establish the relationship of the fistula with the puborectalis in order not to cause incontinence in the patient. So in high fistula, you do MRI, which would give you the clear anatomy of the fistula and the relationship with the muscle. Division of the least amount of muscle in keeping with cure of the fistula should be practiced. Now, if you are dissecting to access the tract, the thinnest portion should be cut, okay? Don't cut through a thick pad of muscle saying you want to access the fistulous tract. You might just completely damage the internal and the external sphincter, including the puborectalis, and patient will just develop incontinence. So the least amount of muscle should be accessed when dissecting to divide. Side tract should be sought, and the presence or absence of underlying disease should be determined. This is especially in recurrent fistulas, complex fistulas. They may be associated with background granulomatous infections. You keep on doing surgery without determining the actual cause of that fistula, there will be recurrence, which may just require you giving a specific treatment for the underlying pathology, and that will do. Now, what are the procedures for low fistula? 1, fistulotomy. If you have a fistulous tract, fistulotomy just means you make an incision to lay open the tract. When you lay the tract open, you see, you have laid the tract open by making an incision. Okay, this is fistulotomy. You get your curate and scrape off the granulation tissue. You leave it open to heal by granulation. Okay, that is fistulotomy. That is laying open the fistulous tract. And this is done for low fistulas using the Milligan-Morgan classification. Fistula that are located below . Okay, we talked about fistulotomy, which is laying open the fistula. Now, fistulectomy is excision. You completely excise the fistula. The fistulous tract, you just excise it completely. Okay, meaning you are having a fresh tissue, not part of the fistulous tract. That is fistulectomy. You can close primarily. Okay, after excision, you close the wound primarily under antibiotics. So you can lay open, or excise and allow to heal by granulation tissue, or you close primarily under antibiotic cover. Now, Park's operation. But these are the two common operations that are done for low fistula. Don't forget, the two are fistulotomy or fistulectomy. Okay? Now, for high fistulas, what do you do for high fistulas? You know, if you just do a fistulotomy or a fistulectomy for high fistula, you are going to damage the puborectalis. You are going to damage the sphincter complex. Now, if this high fistula is secondary to a primary condition, treat the underlying primary condition. You may now give a proximal colostomy if necessary to divert feces from reaching the fistulous tract. Okay? You treat the underlying pathology. You divert feces by giving a proximal colostomy so that feces don't get to the tract and the tract will heal spontaneously. Another technique for treating is by use of seton. Seton, you could use a linen or monofilament nylon to tie loosely around the fistulous tract. Okay? This will serve as a drain, or it may cut through the tract, maintaining the architecture of the sphincter complex. That is what seton does. The seton may be removed 2 to 3 months later, after which time the tract may heal spontaneously. If not, the tract may be divided because fibrosis may cause minimal separation of the cut end. Now, what you do in seton, let's assume there is a high fistulous tract. Let me see if I can. Okay. Okay, let's say you have there is a fistulous tract, a long fistulous tract. Okay. Let me use this as the anal canal. And the fistulous tract is here, a high type. And let's say from this point is the level of the puborectalis. So above this point is high, above this is low. you know, you cannot just keep on dissecting because it's going to destroy the sphincter complex. So what you do a fistulotomy for the parts below the sphincter complex. I hope it's clear. You do a fistulotomy which is lay open the parts below the sphincter complex. Then you now pass your seton suture and tie in the part above the puborectalis muscle so that you do not destroy the part. Now, this seton are two types. It could be loose or taut, the cotton. This is for drainage. It prevents accumulation of pus within that tract. That is the loose seton. While the cotton one, patient comes intermittently, you keep on tightening this knot and it will be gradually cutting through until it's completely cut through the tract, maintaining the architecture of the sphincter complex. So in high fistula, you either do a proximal colostomy, treat the underlying pathology until the fistula heals. Because as feces do not get to the site of the fistula, it's going to heal spontaneously. Or you do place a seton suture. Do a fistulotomy for the low part. On the high part, you now apply your seton, which could either be cut or loose. Okay. Now, for complex, there are other options you can use in the treatment. For complex, deep and recurrent fistulas, injection of fibrin glue into the tract, okay, and insertion of a porcine small intestinal submucosa plug. You can inject a fibrin glue. You can insert what is called SOGI-CIS, small intestinal mucosal plug. This is a biological material that is gotten from porcine that is inserted to plug the fistulous tract. Now, in some recurrent case or difficult cases, you can do a sliding flap as advancement. Okay, the last topic we are going to consider today in benign anorectal conditions is the fissure-in-ano. This is very important and this is common because it's usually seen in patients where they pass a very hard feces and this causes a tear in the inner mucosa below the dentate line. This is common. Or somebody goes to defecate and there's a fish bone in the stool and it causes a tear in the mucosa and subsequently leads to a fissure-in-ano. A painful linear ulcer situated in the anal canal and extending from just below the dentate line to the margin of the anus. A common condition that causes suffering out of proportion to the size of the lesion. In the acute phase, the lesion is often a mere crack in the epithelial surface, but may cause much pain and spasms. Okay. Now, you see, this is common. Sometimes when it occurs, they will be afraid of passing stool, because as they pass through, they will experience pain and spasm of the anal canal. And sometimes they will see blood streaking the stool. Now, fissure-in-ano, how is it classified? It is classified usually according to the duration of the fissure. Fissure-in-ano is classified into acute and chronic fissure-in-ano. Acute fissure-in-ano, usually they present less than 6 weeks. Chronic fissure-in-ano, they present for more than 6 weeks. Anal fissure can also be categorized by whether they are primary, no underlying disease, or whether they are secondary, there's an underlying disease. For example, inflammatory bowel diseases. Now, look at this diagram that is depicting fissure-in-ano. You can see this is dentate line, this is the fissure, and there's a skin tag that is called sentinel pile. Usually, sentinel pile or anal skin tags are associated with chronic fissure-in-ano. It's a sign you see in chronic fissure-in-ano. What are the risk factors for fissure-in-ano? Anal fissures are usually caused by inflammation or trauma to the anal canal. The major risk factors include constipation, dehydration, inflammatory bowel diseases, chronic diarrhea, previous anal surgeries. So how do they present? Usually occur in younger and middle-aged, equally common in both sexes. The locations of fissure-in-ano. Majority, 90% of fissure-in-ano occur posteriorly, while only 10% occur anteriorly in the anal canal. And what is the reason for this? Because posterior part of the anal canal is poorly supplied with blood. The blood supply in the posterior part is precarious. When you see anterior fissure-in-ano, usually it's following a complicated delivery in women. The fissure located in the posterior midline is 73.5%, anterior midline 16%, and both 2.6%. This is by a study by Gordon et al. Anterior fissures are more in females for obvious reasons we mentioned. Occasionally, patients develop anterior and posterior fissures simultaneously. Pain in the anus during and after defecation. So this makes a patient afraid of defecation, and it predisposes them to having constipation because of the fear of defecating. Sometimes when they commence defecating, they have difficulty in even completing the defecation because it triggers a lot of pain, a lot of spasm, and you can imagine when somebody is stuck at the midway of defecation. Bleeding is very common. There's a large sentinel pile. They may have discharge and they may have constipation. Often patients who refuse a digital rectal examination due to the intense pain, an examination under anesthesia may be necessary for diagnosis, except a resident that wants to be a super surgeon, he insists that he must do a digital rectal examination, you inflict serious pain in the patient. Fissures within the anal canal can then be usually identified upon proctoscopy. Now, what the pathology? Acute fissure usually heal promptly with conservative treatment, but may show a considerable reluctance to heal. Failure to heal. When they fail to heal, they become a chronic fissure-in-ano. And the secondary changes you see, sentinel pile, as we mentioned, hypertrophy of the anal papillae, and fibrosis of the lateral edge of that ulcer. There's fibrosis of the base of the ulcer, and the base you see is the internal sphincter, which is whitish, that becomes fibrosed and indurated. They may become infected and predispose a patient to a perianal abscess. What is the pathogenesis of this fissure-in-ano? This persistently hard bowel movement, okay? This perpetuates the condition. Frequently, when there is a passage of hard feces, it causes a tear in the inner mucosa. And subsequently, there is abnormality of the internal anal sphincter. The resting pressure within the internal anal sphincter will be high. Okay, when there is high and abnormal overshoot of contraction, this may cause ischemia, necrosis, and tear, ulceration. Okay, as we mentioned, it is common at 90% in the posterior part because the posterior part is less perfused. Treatment. Now, the first step in the management is to avoid constipation. And how do you achieve that? By increasing fiber intake and fluid intake. When you increase your fiber intake and a lot of fluid intake, you prevent constipation. And you give stool softeners or laxatives. Sit bath. Pharmacological sphincterotomy. Now, you give agents that may release nitrous oxide, and this will cause relaxation of the smooth muscle and increase vasodilatation and flow. This will ultimately relieve the increased anal pressure and the pain will reduce. You can use glycerol trinitrate, calcium channel blocker, commonly nifedipine. This antihypertensive, you know, it can be compounded into an ointment and it is applied into the anal canal. Now, usually physicians, when you are prescribing this topical ointment for fissure-in-ano, you have to describe the application properly, okay? Not just to apply at the opening of the anus. No, it has to be inserted into the anal canal so that there will be relief of the spasm. So patient have to get gloves, okay? He takes the ointment and inserts his finger gently into the anal canal and deposit the ointment. That is how it's going to exert its effect. Not that you are applying it outside and the sphincter will not allow the ointment to go in to the anal canal, okay? You can also give botulinum toxin injection, which will cause relaxation and allow chronic fistula to heal. Muscarinic agonists like betanicol cream, Okay, look at several other drugs that can cause muscle relaxation and increase blood flow to encourage healing. Now, for chronic fissures that have exceeded 6 to 8 weeks, the classic excision is fissure-rectomy, okay, by excising the fissure, okay? But commonly, the internal lateral sphincterotomy is done with a sharp size 11 blade where you incise and make an incision in the internal sphincter to relieve the spasm, okay? Other procedures like V2Y anoplasty, advancement flap technique, anal sphincter stretching. Now, when patients come with a severe pain, you can do anal dilatation under spinal anesthesia. This will also relieve the spasm and pain, and patient continues seat bath, stool softeners, antibiotics, and so on. So in conclusion, benign anorectal conditions are ranges of different pathologies that are distressing to a patient. They may be painful or painless and requires proper evaluation to rule out malignancies. Also systemic evaluation for associated conditions. So we've come to the end of today's lecture. So I'm going to allow you to unmute yourself. If you have a question, you can unmute yourself. Then we'll now go into an interactive session. Thank you very much for participating. So if you have any question, you can unmute yourself and ask. Thank you very much.
Hello?
Yes.
Yes. Thank you very much for the excellent presentation. I really benefited a lot. So my questions are, the first one I had was, I was just wondering about the diet. So we talked about diet being a risk factor for hemorrhoid, and the carbohydrate or refined carbohydrate diet is a risk factor for hemorrhoids, as seen in the study that compared the hemorrhoid incidence comparing Africa and the Western world. So I was thinking, what could be the reason? Is there an interaction between those refined carbohydrates and the anal cushions? I was trying to wrap my head around that. Then the second question is about seat baths with hypertonic saline. About that, there are some not surgeons but medical officers and other medics that I've worked with who like emphasizing on the thing of salt, that salt should not be in the water, it should not be hypertonic. Some say it should be. I'm wondering, what are your thoughts on that? Those are my questions.
Okay, these are very excellent questions. Please, may I know who asked the question? Your name?
Misa. Okay. Tijani Ezekiel.
Okay. Okay, Dr. Ezekiel, those are very good questions you asked. Regarding the first question, the relationship between diet and hemorrhoid, is there any interaction between refined carbohydrate diet and hemorrhoids? Now, what is actually happening here all those diets, all those refined diets are risk factor for constipation, okay? And when patients have constipation and straining during defecation, and straining during defecation, as we mentioned, is a risk factor for hemorrhoids. Because diets that are rich in fibers rather than refined carbohydrate, they have a high transit time. And the bulk of these diets, the bulk of the fiber, the non-digestible fibers, aids peristalsis, increased transit time, no constipation. But high refined sugar, most of the contents are absorbed and you have minimal. So it's a high residue. They remain in a very long time without evacuation from the GIT, and it predisposes patient to constipation and straining, and that will predispose to prolapse of the anal cushions. I hope that is clear.
Yes, very clear.
Okay, then the second question with regard to seat bath with hypertonic saline. Now, preparing hypertonic saline. Number one, how do you make a saline? Let's start with that, hypertonic. When you see hypertonic saline, you know, to create a hypertonic solution, the crystal, okay, must exceed the saturation point. Okay, if you have a boiling water, you keep on adding salt until it stops dissolving. That water has become saturated. You will now see the salt particles at the bottom of the fluid, okay, of the boiling water. That means it will no longer dissolve. It has gone beyond the saturation point. So that is now a hypertonic saline. So you allow that water to cool, to just become a warm water so that it doesn't burn the patient. You now ask the patient to sit in that water for 30 minutes to 1 hour. So how does it act? The mechanism of action of hypertonic saline. One, it causes dehydration and shrinkages of the microorganism. If you remember, we told you polymicrobial causes of the infection when we talked about anorectal abscess. So it kills the bacteria by dehydrating them because it is hypertonic. So water tends to move out of the bacteria into the solution and it kills them. Okay, that is one mechanism. Okay, so it's bactericidal. Two, how does it act? The hypertonic saline reduces the inflammation of the edematous tissue around, okay? Because it's hypertonic, fluid will tend to move from the edematous tissue into the hypertonic saline. So it reduces edema and the inflammation. So these are the two mechanisms which it acts, by which the hypertonic saline acts. So if a patient is doing seat bath without applying hypertonic saline, it means the concept, the aim of doing the hypertonic saline have been defeated, okay? And this is cheap for the patient because salt is cheap and it's just water. So what it requires is for patients' dedication and compliance to treatment. Okay, I hope it is clear.
It is very clear.
Okay. So any other question? There are several questions here, but I would prefer if you will ask your questions rather than sending the questions. When someone say, that is Bikisu Diko, my question is using sclerotherapy for hemorrhoid. Okay. Can we use other oils instead of almond oil? Yes, you can use other oils, arachis, granite oil, but the bottom line, they have to be sterilized. Okay, you don't just go to the market and buy granite oil, take it to the theater and start injecting into people's hemorrhoid. There are commercially prepared oils that are mixed with antiseptics, 5% phenol. Okay, this is an antiseptic plus arachis oil or almond oil. Okay, depending on the product that will cause serve as a sclerosant, but other oils can be used. How does cardiac failure and portal hypertension increase the risk of having hemorrhoid? Okay, that is a very good question. He was saying, because now these are things that will cause ascites. These are conditions that will cause ascites, and ascites will increase intra-abdominal pressure. Now, all causes of increased intra-abdominal pressure, not only straining or constipation or chronic causes, as chronic cough, ascites and intra-abdominal masses can also increase intra-abdominal pressure. Hope that is clear. Yes, questions? Do you have questions? If you have questions, you ask. Okay, I believe since there is no question.
Excuse me, doctor.
Okay. Yes. Yes, I'm listening. Yes, are we together?
Can you hear me?
Yes.
Yes, sir.
Can you hear me now?
Yes, I can hear you. You can go ahead. Ask your question.
Okay. So I want you to kindly re-explain the conditions that do not obey the good soul's law. I got that you have a transverse anal line, you have anterior and posterior. I got those parts of the rule, but the ones which do not obey, you kind of hurried through it. Maybe you could re-explain it for me again.
Okay. Now, you got the Salmon-Gussos rule. It is clear. Is it clear?
Yes.
Now, factors that do not obey, exception. Exceptions to the number one, long anterior fistula. When you say long anterior fistula, if this is the fistula, if this is the anal opening, and the location of the outer opening is greater than 3 centimeters, this is greater than 3 cm. Okay, this is the anal opening, this is the external opening. If the distance between this outer opening and the anal opening is greater than 3 cm, it is called a long anterior fistula. It does not obey Salmon-Gussos rule. Number two, fistulas that are resulting from a chronic granulomatous inflammation or infection, like tuberculosis, schistosomiasis, inflammatory bowel diseases. 3, fistula that resulted from exposure to radiation. 4, fistula that resulted from malignancy. 5, recurrent fistulas. Okay, hope they are clear. Is it clear?
Yes.
Okay. Any other question? Okay, I believe we don't have other questions. So we are going to stop here. Tomorrow, we are going to continue with our lectures. Tomorrow, we'll be discussing multiply injured patients, God willing. So thank you very much, everyone.
Thank you very much, sir.
You are welcome.
Thank you, sir.
Thank you.
Thank you, Doctor.
You are welcome.
Thank you, sir.
Welcome.